Hello everybody, this is Kate Wakelin here, dialing in live or beaming in live to our Facebook community on this Friday the 5th of May 2020, and yeah, it's lovely to be with you again. Before I begin properly, I do want to acknowledge that I am sitting in the land of the Wurundjeri people of the Kulin Nation, and I realise that this is not something I've commonly been doing in our Facebook Friday, but I don't know if you've heard the expression of know better and do better, and I guess particularly the events of the last week have really emphasised to me the importance of doing better in any way that we can for our Indigenous people in this country. And so I pay respects to their elders, past and present and emerging, and I'm very grateful to be here. We talked about this a little bit last week because it was Reconciliation Week, and I just wanted to say thank you to all of the people who sent me messages and emails and let me know what land they were on. Some of you knew the language that the Indigenous people in your area speak, which I thought was really fabulous. And some of you took the time to tell me about the things that you appreciate about living where you live, and the sense of privilege that we all have living here. So yeah, I just wanted to just give some time to that today. It's been a really full-on week for many people who've been watching our media, and particularly people of Indigenous backgrounds, both here and obviously overseas. What we know about cancer in Australia for people from Indigenous backgrounds is that the outcomes are really concerning. We know people are diagnosed later. We know that people don't get access to as good treatments, and the outcomes aren't as good. And so I just again wanted to allow some space for us to contemplate that, to feel grateful for our privilege, and to all undertake to know better and do better as we move on, as we move forward. So an update on coronavirus. I keep feeling like it's the calm before the storm, but as I look back over the videos, I've been saying this for some time, I feel like Australia has been really held up in front of the world as an example of where lockdown and socially distancing has actually achieved the result that we were all hoping for, that the rates are still very low. There have been little pocket outbreaks here and there, and so we all still need to be very careful. And I guess as we are starting to re-enter the community, remembering the importance of things that perhaps might have gone to the background a little bit as we were all staying home so much, but certainly hand hygiene is really important. So keeping those hands really clean, 20 seconds, happy birthday times twice, with soap and water is great. Having some hand sanitizer in your handbag or in your pocket if you're out and about, and if you can't access somewhere to wash your hands. We keep coming back to the conversation about masks, and I was really hoping that I'd have something more definite to share with you. Some of you did log into the live broadcast last week from Professor Sancha Aranda from Cancer Council Australia, and she actually talked about masks. It hasn't come out as an official line, but her informal thoughts were that probably for people where they have a vulnerable immune system, it might well be useful. If you're in a crowded place and it's hard to socially distance, get that 1.5 metres away from each other, then perhaps wearing a mask would be a good idea. And certainly places like public transport, the thinking is a mask is probably a good idea. Surgical masks are the best option, and the shortage of PPE, the protective equipment in hospitals, has really eased. So these can be purchased from pharmacies now. There's also some research into the effectiveness of homemade fabric masks, like made from t-shirts or tea towels, or I think denim has been found to be probably quite effective, and it's because it's a dense weave. And I guess the trade-off is that once it's a dense weave, it can be more difficult to breathe through, and they are very warm and close feeling as you wear them for some time. So you don't have to wear a mask all the time, and if you have an intact immune system, maybe you don't need to anyway, although I keep hearing I wouldn't be surprised if in a few weeks' time everybody on public transport and on a plane is advised to wear a mask. But really the rates of community disease are low still at the moment, so you know, I'm really happy to report that it does seem like the risk is still really low for everybody, which is very encouraging. And I know it's an anxiety provoking time for you all, and we'll keep you as up to date as we can. As soon as I get more information, I'll make sure I feed it in to you all. One other thing about COVID-19 that came across in one of our meetings that we had with some support group facilitators over the last 10 days or so was that there was one report of a person who was told that they weren't able to accompany their partner who has neuroendocrine cancer along to their hospital appointment as their carer, and they'd been told that the person had to go in on their own and not have their partner with them, which seemed really difficult. And it was a very challenging situation for them to navigate, and they asked me what our response was. I've actually managed to get in touch with the hospital who that message was received from, and I think there has been probably a miscommunication. So the message that I've received loud and clear from around everywhere is that certainly one carer is absolutely fine to take 2 medical appointments with you. If you need to have more than one person, that gets a little bit more complicated, but always take that conversation to your hospital. I think I talked a few weeks ago about when things go awry, that video, and we talked about when there is a tricky situation with a clinical team, which does happen from time to time. Every hospital's got a system for feeding that feedback up through the hospital. So if you do have a problem at your particular place of care and you're concerned, then that's the best place to take it to start with. But just to let you all know that the information that I have is that yes, you can take a carer to your medical appointment. So I'm hoping that will be reassuring for those who were worried about that. So the other question I had during the week, which I was hoping I was going to get to, but it turned out to be a bit of a rabbit's warren, and every time, I don't know why I should be surprised, because it's a rabbit's warren every time I look at it, which is medical cannabis or CBD oil. The question was specifically about whether you can drive while you're taking medical cannabis, and the answer to that is, well, it depends. So it's a complex area. We've talked about this frequently in the Facebook private discussion group. What I'm going to do is, in a couple of weeks, I'm actually going to devote a segment to Facebook Friday to this issue, because it's far bigger than I can give a mini update, and I have promised to talk about something else today. So my apologies for not going into this in depth. Quick answer is talk to your doctor about this. Your doctor should have the information about what they're prescribing. There's different forms of these medicines depending on the purpose of them. So it's not a hard and fast answer, and I'm very sorry that I'm not able to give one. But today I did want to talk about somatostatin analogues, because this is something again that we hear a lot about. And this morning I had a phone call, and look, I could have sworn that I had set it up as a Dorothy Dix, because it was just after 9 o'clock, and I sat down at my desk and the phone rang, and here's someone who was having issues with the person who was injecting their somatostatin analog injection. So I'm not going to give too much about that situation away, but just it emphasised to me that, gosh, this is actually still a very current thing, that it's a very real part of your lives for a lot of you. So I wanted to talk to you about it. Just going back to the start, I have talked in a previous Facebook Friday about the way that these drugs work. So the neuroendocrine cancer cells, like normal neuroendocrine cells, have receptors on their surface, and it's a bit like a messenger system for that cell, turning it on, turning it off, telling it when to produce hormones, telling it when to just go to sleep. So somatostatin analog, those medicines actually tap into those receptors, and the idea is that they essentially turn neuroendocrine tumours off. So if I'll put a link to the video. I think it was quite a few weeks ago. It was quite early on in the Facebook Friday series, but I'll try and find that video and put a link to it, because it's actually probably worthwhile that you know how these drugs actually work, because it helps explain some of the things about them. So there's 2 long-acting products for somatostatin analogues, and there's also a short-acting, and that's really important to know. The confusing thing is that one of the long-acting and the short-acting one have a really similar name, which is Somatostatin. So I wish they would call it a different thing so it was less confusing. So there's the short-acting Somatostatin, which is the name of the actual medicine is called octreotide, so it's also called short-acting octreotide. Sometimes people will go on to short-acting octreotide to make sure that they will tolerate it before going on to a long-acting monthly type injection. Or sometimes people, when they get carcinoid syndrome symptoms that are breaking through, that even though they're on those monthly injections, they're still getting lots of symptoms. Sometimes they'll add in those short-acting injections as a supplement. Sometimes also we will give a short-acting version when there is a procedure happening, like some dental work or surgery on tumour. They'll give an infusion of short-acting octreotide to help just settle any tumours down, to make sure they're not going to get too excited and squirt too much hormone out. So that's the short-acting version. The short-acting one, I don't have an example of the actual syringe, but it's a small needle. It's a bit like a diabetes needle. It's not a pen, but it's a small needle that just goes under the skin in the tummy, and that's a true subcutaneous injection, which means just into the fat. And lunchtime again, and I'm going to be talking about needles and fat and all sorts of things, so my apologies. You might just want to put your lunch aside if you're particularly delicate of stomach, although most people living with this, it's bread and butter conversation anyway. So, so the 2 long-acting products, one is called Somatostatin LAR and the other one is lanreotide, or Somatuline Autogel is the other trade name for that. They're generally given every month. Sometimes for some doctors, if you've got difficult symptoms, they might bring the frequency closer together. Sometimes they'll actually bump up the dose and you'll get 2 injections, so 1 in each side. So there's some ways that the doctors out there do tweak those dosages, but generally they're designed to be a monthly injection. So I'm going to talk about Somatostatin LAR first, and then I'm going to talk about lanreotide. So Somatostatin LAR is given by intramuscular injection, and I've got a syringe. Now this doesn't have real Somatostatin LAR in it, and anyone who's on this will know because it's clear as day, it's just water in there. But I did want to show you what they look like, because if you're on lanreotide and people are talking about Somatostatin LAR, it may be helpful for you to see what the difference is. So in a minute I'll pick up the lanreotide injection and then I'll put them side by side. But this is the Somatostatin LAR injection, and for those of you who are squeamish, you might want to avert your gaze, and I'm just going to show you the needle size. So it's quite a hefty needle, and it goes right into the muscle. So it's very sharp, and people tell me the actual needle going in is often not the bit that is the most uncomfortable, but it's about injecting the solution inside, which is quite thick. So there's a couple of things that are really key about those injections that people who have had the training in giving those injections should know really well, but sometimes it's very different from giving a normal injection. So if you're going to a hospital where this is being done and the nurse might be only giving 1 or 2 of these a month, they may well get the instructions out, and I actually think that's a good sign. If they're getting the instructions out, that's much better than kind of blundering through and pretending that they know what they're doing when maybe they might be well advised to refresh the instructions. Really, a very important thing about both of these medications is they need to be given at room temperature. So the Somatostatin LAR, particularly in the past, a previous formulation had a really terrible reputation of blocking needles. It's a solution. It's a bit like soluble Panadol. So there are particles, very small particles of the drug inside the liquid. And if that's reconstituted when the liquid is too cold, it doesn't dissolve well. One of the reps actually told me it's a bit like Berocca. I don't know if you've ever tried to put a Berocca tablet into really freezing cold water from the fridge, but it won't dissolve. It's sort of a bit lumpy and it sits down the bottom of the glass and doesn't do anything very much. Or maybe if you're in Canberra, the water out of the tap would do the same thing, because I hear that Canberra was very cold this morning. But if you put it in room temperature water, the Berocca dissolves. It fizzes up, it dissolves. Well, Somatostatin La doesn't fizz, but it does dissolve much more effectively in room temperature, in the room temperature liquid, that's diluent, that's in the package. So it's really important that it's out of the fridge for at least half an hour. Now, it's stable at room temperature up to 24 hours in total. So if it's out of the fridge for a couple of hours, you can, and you change your plans, you can actually put it back in the fridge, as long as that collectively doesn't add up to more than 24 hours for the life of the drug. That's no problem at all. But getting it out 10 minutes before the injection's going to be given and trying to reconstitute it when it's still cold, it's just, A, it hurts more, I'm told, but B, it's much more likely to block a needle, and that's where you get the horrible situation where the nurse has got to take it out of your bum, change the needle, and put it in a slightly different location. And look, we want to avoid having to prod you with needles as much as we can. And so, yeah, room temperature is really key. Some people ring their treatment centres, when they're leaving home, if they're an hour away, to remind them to make sure it's out of the fridge. Some treatment centres take all of their doses out of the fridge the morning that they're due to be given, knowing that if the patient, gets waylaid and doesn't turn up, if it's only been sitting out of the fridge for a couple of hours, then it can go back in the fridge with no problems. So, there's some strategies that sometimes people use for making sure it's at room temperature, but that's really important. What else do I want to tell you about Somatostatin La? I think I'm just going to tell you about the lanreotide, and then I'll come back to sort of talking about the two of them. So lanreotide is a really different syringe. So I've got one here, and again, this doesn't have actual drug in it, as you can see, because what's in the barrel of the syringe is clear. This is normally like a whitish or pale creamish kind of liquid. And just to give you an indication of what the needle looks like, it's still a fairly hefty needle, but it is shorter. It goes in what we call deep subcutaneously, and this is the thing that trips up some health professionals, because this is the only medication I've ever come across that's given in this way. So a subcutaneous injection normally, as I said to you before about the short-acting octreotide, just goes under the skin in the tummy, and normally a nurse would pinch up the skin to give that injection. For this deep subcutaneous injection, they don't pinch the skin up, they have to spread the skin out. It goes a lot deeper, it goes in at 90 degrees to the skin. There's a whole lot of, quite specific instructions for this medication that are really different to if you're giving a normal subcutaneous injection. So again, if your health professional pulls out the instructions and you see them reading it really carefully, it's good, because you want them to know that this is different from other medications. Again, just like Somatostatin La, it needs to be given at room temperature, and for both of these medications they need to be given slowly. So we're talking 20-30 seconds. Sometimes people even want them done even more slowly. What I hear is that when they're rushed, they hurt more. I also hear anecdotally that they're potentially more likely to give you a nasty lump if they're given over a short period of time. As a nurse, I actually hate giving these injections, and it was really useful for me when a patient said to me, "Stop apologising about giving me this injection because it makes it feel worse." And I'm like, oh, right, thanks, okay, good. I'll try to stop doing that, but I hate giving injections. So sometimes when you're doing something you hate, you try and get it over with quickly. It's a bit like sort of thinking, oh, well, I'll pull the band-aid off quickly. And a lot of injections are great that way, like a flu jab. Get it in, get it out. I want it out of me as quickly as you can. These injections are really differently. We actually want our health professionals to be taking their time. It's okay to remind your health professional if you feel like they're in a rush, just say, just checking in, this is a slow injection, 20 to 30 seconds, 30 seconds to a little bit longer if that's what you want. Feel free to advocate for yourself in that way. It's a little bit nerve-wracking to do. It's quite vulnerable when your bum's in the air and they're about to poke you and you're going to ask them to change what they do a little bit. So I'm just, but anyway, slowly is good, fast is not great. I'm just going to show you the two ones side by side because I think maybe that might be helpful. You can tell me whether it's helpful. I haven't had any comments so far, so that's all right. But maybe you're all engrossed. I can see a few people have zoomed in or dialed in, beamed in. So anyway, these are the two syringes. You can see the Somatostatin LAR, I don't know, 6, 1, half a dozen of the other. Somatostatin LAR, the injection's skinnier but longer. Lanreotide, the needle is shorter but a bit fatter. The other really important things about these two medications. So Somatostatin LAR is designed to only go in your backside. It's not supposed to go anywhere else. Lanreotide can go in your backside, or it can go in your thigh. Now sometimes people tell me they've had them given into their tummy. They're not supposed to be given into your tummy. So if you've got a health professional who's doing that, you need to just check up on the instructions because it's not supposed to be given in the tummy. There's too much fat usually there. It needs to be given quite deep and close to the muscle layer. So into the buttock or the thigh is the place to go. The other thing about Lanreotide, which a lot of you will know, is that it can be given as a self-injection because you're not craning around to inject into your own backside. I'm just, I do like a bit of yoga, but doing yoga and an injection simultaneously does seem to be a little extreme. So there are programs for health professionals to be injecting the Somatostatin LAR, whereas Lanreotide you can self-inject. So it's probably a good time for me to talk about the two self-injection programs. And maybe I'll talk about Lanreotide first, just to make sure that I'm sharing the love around equally. Really importantly, I don't have a preferred one. Like I'm not aligned to any particular drug or any particular drug company. I just thought it might be worthwhile me sharing the options with you. And some of these videos I know we're putting up onto our YouTube channel. I think we probably won't make this one available more broadly. It's going to be just for the group members. I don't want to be misinterpreted as promoting any of these drugs, but knowing that many of you are on them as a mainstay of your treatment, I think it's really important that you know about them and that you know about the differences. So, Lanreotide home injection. The program is called Assist Beyond. Now, it can work in a number of ways. It's really a support program to enable you to have the injection in a place that you want to have your injection, and whether that's at home, you giving the injection, whether that's you at home with someone in your family or a friend or a carer giving you the injection, or whether it's at the local healthcare, like, where your local GP clinic and the nurse or the doctor there giving you the injection. The program is called Assist Beyond and it's free of charge. It provides training for the person, whoever it is, to give that injection. So for you, it might be the nurse coming to your home for usually 3 visits to help support you in giving that injection independently, or someone in your home, or as I said, they can train a health professional in your local community to give that injection. Now, in a very small number of cases, they can provide a nurse to the home to provide those injections on an ongoing basis. There's a very strict assessment criteria for that to happen. So if you're frail and elderly and it's difficult to get to a service provider and you don't have someone who can come to your home, and look, a lot of people have arthritis in their fingers and it's difficult from a dexterity point of view, it's always worth having the conversation about whether that's possible to save you a long journey. So that's the Assist Beyond program. Somatostatin LAR, their home injection is called the eShine program. It used to be called Shine and they needed to change it. So everyone needs a rebrand every now and again, don't we, Neuroendocrine Cancer Australia? So anyway, they are eShine. They provide health professionals to come to your home or to wherever you are to provide your injection, and it's either a GP or a nurse, and they endeavour to have the same person each time, but obviously sometimes that's not possible if people are on holidays or people are away sick, or it's a different time of day or day of week and it just doesn't work out. But they do try and make it the same person each time. And I've got, I know there's several people in our group where they've had the same eShine nurse for years, and actually you get to know each other really well. And that's a lovely thing about these sorts of programs, is that you can develop that relationship, which we know is so special for people and important. So Somatostatin LAR is the Assist Beyond eShine program. Nearly got it wrong. I knew I was going to slip up at some point. The other thing about the eShine program, which is a bit different to lanreotide, eShine also give a rebate for the chromogranin A blood test that lots of people with NETs need. They give a rebate up to 4 times a year for that blood test, and they also have a rebate for PET scans. Mostly that's done through the hospital, so mostly they provide some funding to the radiology departments that perform those scans. So a lot of you, the eShine program might be providing funding for those scans and you will never know about it. It's not like it's a form that you have to fill in. With the chromogranin A, it may well be a form that you need to fill in. So if you're paying for chromogranin A blood tests and you're on the eShine program, let me know, or call eShine and they will give you the information about how you apply for that rebate. The blood test's about $60 a pop, and I think they, oh gosh, I was going to print it out and I didn't, but I think it's $40 rebate that they give you up to 4 times a year. So it's actually quite significant, and if you're not getting that, well, you might as well, because, you know, it's money you don't have to spend. The other thing about Somatostatin LAR that is just new, it's just hot off the press, is that they have decided to support a home delivery service. So that's not home injection, it's home delivery. And what they're doing is that they've engaged with an online pharmacy company whose sole purpose in life is to deliver medications to people in their homes, and they do it with lots of other medications. Who knew? I didn't know about that. So what they do is they deliver it to your home in an esky, so it stays nice and cold at a time where you know you'll be home. At the moment that's really easy because most of us are home all the time, but certainly at a time where you're going to be home. The charge is just the charge of the co-payment, so it's about $6 or so, but there's no dispensing fee. So for those of you who might be paying $20, $30, $40 plus dollars at the pharmacy to get that prescription filled, there's not that dispensing fee, there's just the co-payment, so about $6. They deliver it to your home, there's no charge for the delivery. You don't have to be on the eShine program to get this drug delivered to you. So you might be having your injections up at the local hospital, and you want to bring it with you at room temperature. Just a hint, you might be having the injection at the GP. You might have your eShine nurse or GP coming to your home to give that injection. This is about getting the drug to you so you can keep it in your fridge. And obviously you need to make sure that your fridge is good, that it's been kept at the correct temperature, that you're going to be home to get it out of the esky which you put on your doorstep, all of those things. But it's an exciting extension of a service which I think is going to be really useful for people, especially during coronavirus season, but actually ongoing. You know, if we can avoid you needing to go to the pharmacy one extra time, if we can help avoid, you know, an extra charge financially, then that's a great thing. So that's the home delivery service, and I'm going to be putting information about that, plus the contact numbers for eShine and Assist Beyond on the website. The last thing I wanted to talk about and now you'll know why I didn't have time to talk about cannabis oil, because there's actually a lot to talk about with these drugs, is that it's actually a really common thing for people to ring me and go, oh, Kate, it just didn't go well today, you know. The needle blocked, they had to have a few goes, the nurse didn't know how to give it, I had to wait, it was freezing cold, you know, and I think when perhaps for years you're getting the same injection every month, it becomes really evident when things may not be going as they probably should be. And we want you to be having this injection in the way that it should be. We know it works better, it has less side effects, it hurts less. You know, there's just advantages everywhere, and we actually want health professionals to feel really confident about giving these medications as well. As a nurse, I hate it when I feel out of my depth, so we want to make sure that we've linked health professionals into the best support and education, and it's there in spades. So sometimes it's just about connecting the wires. Now that's tricky when you're the patient, because there's nothing more vulnerable than having your bum bared and feeling like you've got something to say to a nurse that might be uncomfortable for them to hear, or that might make them feel like they're being checked up on, or, you know, it's tremendously awkward and very vulnerable. We know that. So I wanted to talk to you about that, and again, there's the Facebook Friday video of when things go awry. I will link to that in the notes because I think it's worth another watch. It's your right to get medication administered to you in the correct way. So that's really important for you to know. Of course, we want you to communicate that about that in a really gentle way. If you're talking to a person and you're not feeling like the message is getting through, maybe you're not talking to the right person, so maybe you need to talk to the nurse unit manager if it's an oncology department. Maybe it's the patient liaison officer of the hospital. You know, you can take it up levels, talk to your doctor about your concerns. The other thing that sometimes we can just informally, sneakily kind of do is, if I do hear that Timbuktu Base Hospital Oncology Department only have a couple of patients with NETs, so the nurses don't have to give that injection very often, and they're really busy. They've got a lot of other drugs to get their heads around, and so this is one that sometimes falls by the wayside. And sometimes some people who go there feel like the injections are a bit rushed, or that they're pinching the skin when they should be squeezing it out, or whatever it is. I've got some contacts with the drug companies who do the training for health professionals in hospitals. The drug reps go to the hospitals and, you know, give updates about the medications on a regular basis. So it's not a difficult thing for me to just very gently say to the rep, to say, Timbuktu Hospital, how has it been a while since you've been there? Have you done a nurse's update on how to give the injections? And they'll say, oh, well, we went a couple of years ago, and I'll be thinking, yeah, 6 of their nurses have gone on maternity leave, and they've had a whole lot of new grad staff come through, and, you know, so maybe it's a complete staff changeover since then. So I might just say to them, look, you didn't hear it from me, but maybe it's worthwhile going in and doing another little, a little update, and no names are mentioned. You know, we can do this without even saying it was from patient feedback. So one of the little advantages of having a nurse attached to Neuroendocrine Cancer Australia is that I am able to pass that feedback on in a pretty sensitive way. And for some people, that's going to feel more comfortable than passing the feedback on directly themselves. We know that's difficult. So if that's an issue for you, don't please all ring me this afternoon, because I've got people already on my list to call. But please do feel free to get in touch with me, and we can help troubleshoot that out. The other thing I just wanted to say, I've talked a bit about side effects in other videos, and I didn't want to go into depth about individual side effects because that is another Facebook Friday on its own. But the drugs are actually fairly equivalent. The clinical trials that have been done on them, they are a little bit different. They have used slightly different patient communities, but they target the same receptor. They are very similar in terms of their molecular structure and the way that they work on tumour cells. So a lot of doctors will have the opinion that they're fairly equivalent. So if you're on one drug and it's just a nightmare, you know, you're getting horrible side effects, you hate the injection, or it might suit you better to have a health professional come to your home, or be able to go and self-inject. You know, there's advantages and disadvantages and things to consider for both products. But if you're on one and you've been on one for a while and it's just not really working for you, it's actually okay for you to ask your doctor about, you know, well, I heard there was another one. Is there anything that we could gain by having a conversation about whether I could give the other one a try for 3 months and just see how I go? They might have a good reason. It might be about your tumour. You know, there might be a really good reason to stay on what you're on. But, you know, it's okay to have the conversation. Doctors are not God, much as my mother needs reminding, as she's very meek and mild and not wanting to ask questions. But I know a lot of you feel the same, that it's really quite confronting and difficult to ask our health professionals if we're on the right treatment or if it might be worth trying something else. But actually that's okay to ask them, if you ask them nicely. I don't know a net oncologist who would get their feathers ruffled about that, and if they did, then I think that says more about them than you. It's absolutely fine to ask. So that's all I'm going to say about somatostatin analog injections. There might be a few things I remember I was going to say that I didn't get to write down. I'll put them in the notes if they come to me. Put your own comments. I'd love to hear your experiences. I had a couple of people comment before the feed saying they've got great butt harpoon nurses and health professionals, which is fantastic to hear. And I know that's actually the vast majority of people actually have really positive experiences of these medications, and they work really well, and they calm their side effects down, they calm their symptoms down, and a lot of people have had long-term tumour control from these drugs as well. So, you know, sometimes things don't go to plan, and it's good to talk about if that happens. So just a couple of little housekeeping-y things before I wind up for the day. The first thing is that you might have seen a plug from me during the week that next week on Facebook Friday, I'm really delighted that Associate Professor Ben Thompson is going to be joining us. Now, when we do the interview style things, it's a little bit precarious. You might have noticed if you've watched them. I don't know what it is. I've talked with my family. My youngest child's gone back to school, so it's not her streaming Netflix. Who knows? But if I wriggle my left toe on my left foot, or my little toe on my left foot, the internet drops out and it's all gone. If the internet drops out next Friday, my apologies in advance. I'm going to keep going with the conversation with Dr. Thompson, because he's a surgeon and he's incredibly busy, and it's very generous of him to donate his time. I'll continue the conversation. I'm recording it on my computer, so at worst we will put the recorded version up for you as soon as we can afterwards, and fingers crossed, if the latest it would be by close of business on Friday afternoon. But because of that, I'm encouraging people to write their questions in ahead of time. I've seen some really great questions. One of the questions was around medication. So Ben Thompson, being a surgeon, he's not going to be probably so interested in answering questions about medications, but certainly about surgery and neuroendocrine tumours. He's a really fantastic resource, and he's very keen to talk about the things that are important for you. So hop in with your questions, and I will look forward to seeing you, and I'll just be really hoping that the Facebook fairies really, are kind to us and we actually get to do this live, because I'd love to see the questions that come up and the feedback that comes up at the time. The other thing, a couple of things. Our face-to-face, the groups that would normally be running face-to-face at the moment, they're coming up. There's a couple that have already happened, more coming up next week and the following week. So stay tuned for emails about those groups that do contain the links for the Zoom meetings, because obviously we're not meeting face-to-face at the moment. The other thing just to mention is that our online Zoom group, our open Zoom group that's not attached to a location, but our regular Zoom group that's just started, will be catching up next on the 16th of June, and it's an evening meeting. So for those of you who are working or find daytimes difficult, this one's an evening meeting. So Tuesday the 16th of June, which I think is Tuesday week. So I'm really looking forward to the conversation in that group meeting as well. So I'm going to wind it up there. It's been lovely to check in with you and see you and tell you a bit more about somatostatin analog injections. I hope that might have cleared up some of the questions that people have. I'm sure that there'll be ongoing conversations about these things, and I'm always very happy to revisit and answer questions as they come up. So thank you everyone, and I will look forward to seeing you next Friday. Take care.